You know, one of the things as an antibiotic stewardship person who does this day in and day out is really the lack of availability of rapid susceptibility. You know, I think that is really one of the biggest challenges that we who are involved in the antibiotic stewardship world really face on the floor when we're interacting with providers, because you see so many times where even if you know what the bug is, without full susceptibility, a lot of times our providers are, rightly or wrongly, depending on your perspective, really unwilling to de-escalate without all of that information. So kind of with that as our general overview, what we're going to do is step through these various topics fairly quickly. I really want to start with some rapid diagnostics and basically money. Because one of the things that I've really discovered is that there is only one place that hospital administrators like to spend money less than pharmacy, and that's micro, okay? So really, pharmacy and micro should be donuts. We should be best friends. We should be doing pizza for lunch together all the time. You know, it should be a mutual admiration society, because we both really struggle with budgets that are perpetually under scrutiny. And when those of you who are involved with the micro lab know that a new expensive technology comes in, one of the first things the C-suite does is, how are we going to pay for this, right, on an already tight budget? So we need to talk about that a little bit. I then will keep the promised PK/PD overview very brief, but then we'll talk a little bit about how the results and the ability to have rapid MICs really kind of feed in to our daily stewardship practices and better optimizing care for our patients. And then we'll also see, as we move through this kind of consistently, a discussion about why just knowing the gene isn't enough. You already saw from Keith in some of these early cases where results with just genes spit out potentially really lead to confusion and in some cases, potentially really bad outcomes for patients. So we'll talk about these topics as we move forward. So this talk to me was made a whole lot simpler a couple of weeks ago when Robin Patel's group published in CID their paper looking at the impact of rapid diagnostics on outcomes at the Mayo Clinic. So let me orient you to this slide a little bit. The yellow squares are basically the identification of the organisms that, you know, basically at that point you know what the bug is. The green squares are escalation of therapy. All right, and so that's what happens there. What I want you to focus on a little bit is the yellow downward triangles, okay? Those yellow downward triangles, to me, in an antibiotic stewardship world, are really where the money lie. That is de-escalation. Okay, that is the point at which de-escalation occurred. And then you can see out there the white rectangles with AST in it. That is the point in time at which you had full antibiotic susceptibilities reported out. And across the top there, you can see that the units are measured in hours. So as you move across, you're going from 0 to 12 to 24 to 36 hours and so on. Now, you had 3 groups in this study. And these 3 groups are represented down the far left side of the table. You had a control group in which you basically saw standard workup of blood cultures, okay? Now the thing to remember at Mayo and why this data is potentially not totally able to be extrapolated to a lot of other institutions, it's Mayo. Okay? They have all the toys. They have all the goodies. Everybody's getting MALDI. Everybody's getting PBP2 screening on Staph aureus blood isolates. They've got an antibiotic stewardship team. It sounds like they've got Theradoc, although they may have some other system in place. Something that sounds a whole lot like Theradoc is described in the paper. Okay? So there are a lot of things that are very advanced stewardship practices that are already in play, even for the control group. All right, so when you step down into the next group, this is rapid multiplex PCR. So think of it as a biofire, and that's basically what it looks like, is the biofire film array that some of us are used to playing with. So this is a rapid multiplex PCR that's in play, but it's without antibiotic stewardship backup. So there was an extra step or an extra piece of antibiotic stewardship that was placed into the third group. That third group gives you all of the goodies plus the rapid multiplex PCR plus an additional antibiotic stewardship intervention. you'll notice that the only place you really see a difference is down there in the bottom. In the rapid multiplex PCR plus antibiotic stewardship, you see that the de-escalation occurred roughly 24 hours earlier than it did in the other groups. This is a consistent finding throughout the stewardship literature with rapid diagnostics, that just the presence of rapid diagnostics without an effector arm really doesn't accomplish much. It's really the antibiotic stewardship programs that take these results and then run with them. And then this leads to the more rapid de-escalation that we all want to see, the more streamlined therapy, the discontinuation of therapy where appropriate, that we all want to see in an era of more resistance and an era of increasing emphasis on antibiotic stewardship. So when you look at this, again, remember that this is out of Mayo, remember all of the background stuff that is in place, but what becomes very striking is that just the addition of the rapid multiplex without the stewardship thing didn't really change much, even though your ID occurred very early on. And to me, this was very interesting data, but it was also very confirmatory to our own experience at Oregon Health Sciences University with the implementation of the Veregene system, where we've seen some very similar types of results. The other thing that I think really pops out at you when you look closely at this paper is that the duh moments perform very well. And when I talk about the duh moments, what I'm talking about are the easy things, okay? If it's MRSA, you need Vanco, okay? If it's MSSA, you don't need Vanco. And if it's a group A strep or a group B strep, you can easily step down because you know the susceptibilities. And you really saw this when you looked at the paper here and you looked at the impact on gram-positive versus gram-negative outcomes. The gram-positive arm was much more likely to change quicker than the gram-negative arm. And I really believe that the reason for that is because providers, when they're given MRSA, you immediately know what the susceptibility is, right? You know you need to use vancomycin there. When you get an MSSA, you know it's nafcillin, it's oxacillin, it's cefazolin. You don't need additional susceptibility results. And that's really what this data kind of shows, is that for gram-positives, the ID does well for you because you can infer susceptibility from the ID. It's on the gram-negative side that really you don't see things change. And what this does, again, to me, is reinforce our experience at Oregon Health Sciences with the implementation of Veregene, but also really re-emphasize that clinicians with gram-negatives recognize that there's a lot of complexity with gram-negatives there, and there are multiple mechanisms, as the cases elucidate, through which you can develop or see resistance. And so you really need that susceptibility back, not just the genetic result, before you're going to see de-escalation. And I think this study really does a nice job of showing this. Now, the other piece that I think this study really creates a challenge for us in is where ID, pharmacy, infection control, and lab are all going to have to get together and talk from an antibiotic stewardship perspective about how to cost justify these systems. Because when you look at these outcomes, and again, to me, this is now kind of the gold standard data set in this area because it's really the first time we've seen a prospective randomized data set with multiple different interventions in play. To me, again, this is really now the gold standard as far as the evidence goes. And unfortunately, we didn't see a lot of the things that the C-suite is going to want to hear. You didn't see a significant change in length of stay. You didn't see a change in length of ICU stay. You didn't see a change in 30-day mortality, okay? And then worse yet, you didn't see a change in overall hospital costs. And then finally, what you did see was the cost of the testing go up. You know, so this is going to be an area where we need to talk a lot further about how we're going to justify the spend on these systems going forward. And I think one of the real questions is, can we improve these numbers with rapid susceptibility, especially on the gram-negative side? Because I think we can, and I think that the gram-positive data from this study really kind of hints at that. And again, our own experience in Oregon has been that on the gram-positive side, de-escalation is not a problem because the bug and the gene largely tell you susceptibility. On the gram-negative side, it remains a different story when you don't have susceptibility in play. So I noticed that roughly a quarter of you just went to sleep. Wake back up, okay? And it's really kind of funny because now I know who the pharmacists in the room are, because the pharmacists went, ooh, PKPD, and they just lit up like a Christmas tree, okay? Now, I am not going to dwell on this in this room because there's a lot of smart people in this room who know the PK/PD stuff pretty well. What I want to remind you of is the denominator. What is the denominator in everything we do from a PK/PD standpoint? It's the MIC, stupid, to quote certain very well-known individuals, okay? The MIC is really the key. You can't plug a gene into your PK/PD equation. Have you ever tried to put KPC into a math equation? It will cause your scientific calculator to explode. It does not go well. And so, when we're starting to talk PK/PD and thinking about how to tailor dosing, again, it really comes back to our need for the MIC. And that is consistent for our beta-lactams as well as our concentration-dependent killing drugs. The other piece of the story that is really increasingly keeping me awake at night from an antibiotic stewardship standpoint is this paper from Jason Roberts' group in CID last year. So let's stop and think about this for a minute. We've already talked about you've got delays in MIC reporting, and that's before we even talk about the inherent variability that occurs within the MIC. The MIC is not a laser-guided bomb. Remember that the standard deviation on that test goes 1 tube either way. Okay, so you already have a system with some variability induced to it. Now this paper comes along out of Jason Roberts' group and basically says, we looked at this across a whole bunch of ICUs, and do you know what we found? We found that using standard antibiotic dosing in a lot of these ICU patients, because of the huge variability in pharmacokinetics that you see in critically ill patients, a lot of these patients may be getting underdosed. So now you've got issues with your MIC and you've got issues with your pharmacokinetics. This becomes a real PK/PD nightmare in a big hurry because now both your numerator and your denominator are moving on you. Okay? So this as a pharmacist, for those of you who don't know pharmacists, we are very type A individuals. We do not like uncertainty. And so when you start moving both of our variables on us at the same time, we get very upset very quickly. And when you look at the results of the Dolly study, you see here consistently, and what I want to point out to you is column 3, because I don't know about you guys, but at Oregon Health Sciences as well as at University of Texas in San Antonio, when you were admitted to the hospital, you got Piptazo. And Keith talked about one of the major problems we're having currently is a national Piptazo shortage, which basically causes most of our medical and surgical residents to scream and have their head explode. But once we've kind of gotten their head around that they can use other antibiotics, it's gone okay. But look at the piperacillin, all right? Piperacillin down there in column 3. Remember that the minimum that you want is 50% free time above MIC. 20% of your patients aren't getting there with standard dosing. 1 in 5. Okay? And you see this problem consistently throughout the ICU in a variety of different drugs. And again, the issue is we're not even sure that 50% time above MIC is always the right answer. Is it different in lungs? Is it different, in other sites? So we're struggling, and now we're having to wait on the MIC for some of these more critically ill patients. So you've got variability in your pharmacokinetics and delays in MICs, which are really, I think, compromising our ability to deliver timely, effective therapy, which we've seen consistently be an important predictor of outcomes. So let's come back to the first case that we kind of talked about here. You have a 70-year-old male with a history of COPD, and Keith rolled through this really nicely. And you look at this case and you say, okay, this makes perfect sense. And we've already kind of talked about how the molecular testing was a little bit misleading here and really kind of results in a problem for us. Whereas if you had an MIC here in a timely manner, you wouldn't be relying on misinterpretation of gene results. And so I think, again, it adds a layer of patient safety when you actually have that susceptibility back in a more timely manner. Because again, remember, this was a 70-year-old guy who you're showing aminoglycosides to. That very rarely ends well in our intensive care units. And this slide comes from Tom Lodice's now classic paper in 2007, looking at extended infusions of Piptazo and looking at optimizing your time above MIC. You saw the exact same thing thing with cefepime with Kristen Bauer a couple years later. So a lot of us have gone to these extended infusions to try and optimize our time above MICs. Again, having that MIC result in a timely fashion really allows you to tailor up or potentially tailor down, if you're seeing adverse events that you think may be drug-related, the therapy in a more timely fashion. And we've seen that this works repeatedly, although we haven't seen it in the randomized type studies that we would like to see. I think that Kristen, the editorial that Stan Derazinski wrote in CID, and after the release of Kristen Bauer's paper, kind of says it all, that the preponderance of evidence now suggests that extended infusions are a good thing in our critically ill patients, and having those MICs and knowing when we need to do these extended infusions and really do things to try to optimize the pharmacokinetics of the drugs because of the problems we saw in the Dolly study really become important. So that rapid MIC can offer you an awful lot. When you look at case 2 and you look at this again, remember the CTX being negative here really was a head fake. And when we looked at this several years ago, what we saw in San Antonio was that we had a significant number of CMY type AMP-C enzymes. So the other problem with relying just on your genotypic markers is that there are genes you aren't looking for, or there are genes that haven't been discovered yet. And so if you have the susceptibility available to you, you don't have to worry about that. And we saw, I think, very nicely in this case right here, how that really impacted the patient's outcome. And this is a little bit of a change in pace because this is KPC data, but again, another very good example from the KPC field as to how the MIC appears to really kind of impact outcome here. When you look at this Tumbarello paper that was published a couple years ago now in CID, what this paper says, or what the authors concluded from this paper, was that triple combination therapy resulted in optimal outcomes. I'm not sure I buy that, because look at the rates of success as you move up the meropenem MIC. The other thing, too, is to remember that the meropenem in this study was dosed at 2 grams every 8 hours, given as an extended infusion. The PK/PD data suggests that you can easily handle MICs up into the 4 range with that type of a dose. And you probably had a good chunk of these folks with impaired renal function. So they were probably doing even better than that as far as serum concentrations go. But again, this is an MIC piece. If you get an MIC back of greater than 16 based off these results, are you going with the carbapenem-based therapy, or are you moving on to something newer, such as the ceftazidime, maybe Bactam? So I think, again, really kind of illustrating that in a world of more complicated gram-negative resistance, that the MICs become extremely important to us as far as patient care goes. And we talked about this a little bit, and so I'm not going to dwell on it, but again, I think that meropenem MIC piece here is really kind of eye-opening. And then finally, to wrap up, as Keith illustrated in his case, the MRSA debate over MIC of 1 versus 2, that is a swamp I'm not going into up here today. But what we do know from Natasha Holmes's paper a couple years ago is that even in MSSA, that a vancomycin MIC of 2 appears to negatively predict outcome, or it basically says your outcomes aren't as good. Is it a source issue? Is it a who gets an MIC of 2 issue? Who knows? But why are you seeing differences with MSSA treated with flucloxacillin if it's solely a vanco PK/PD issue? So I think that there's a lot of issues in that swamp, and there's big gators in that swamp too, by the way. We're now talking about splitting half dilution MICs. Remember that variability comment that we were talking about earlier? I mean, this is all kinds of fun. But again, if you have a system that can reliably and accurately give you rapid MIC results in this situation, and a patient's not doing well, perhaps it triggers you to move to a dapto, to a ceftaroline, to a linezolid a little bit more quickly than you might otherwise, and potentially improving the outcomes of your patients. So to kind of wrap this section of the presentation up, I think that really the cost justification piece is going to be a challenge for us moving forward with these rapid diagnostics. And I think we're going to need a lot more economic data because Robin's data, I think, is very sobering. And it really, at this point, to my mind, is kind of the gold standard of the data at this point. resistance genes are hugely helpful, and especially in an area where you kind of know what your epidemiology looks like, but there are certain situations in which clinicians can be misled, or there's a gene there that your rapid diagnostic isn't looking for, and it can come back and bite you. And so I think really the MICs matter. And from a PK/PD standpoint, everything we do uses MIC in the denominator. And so I think that's a huge issue for us, and another reason that rapid MICs, I think, really are where we need to be in order to see better results as far as gram-negative de-escalation goes. And I think that's what Robin's data shows to us very nicely. And knowing the MIC of the organism, really, again, becomes very important when you've got a patient in the ICU and their pharmacokinetics are all over the place. Say it's a 24-year-old AML patient who's blowing through a gram every 4 of vanc to keep him above 10. How aggressive you go with his gram-negative agents will largely depend on what that MIC looks like. So, the variability that we see in the pharmacokinetics in the critically ill patients, I think, just make these rapid MIC results that much more important. And with that, for those of you who know me, that was getting me to shut up and sit down in like 20 minutes is a major accomplishment. So I will actually do that now, and I think we're going to, at this point, move it to the Q&A session. All right.
Thank you so much for that. So I'll start with, I have a question for Steve, and for the system, for the rapid susceptibility, do you think that there might be a future where you have a sort of an open system without an identification, meaning you put your own identification into the system and you can then use that system to generate a susceptibility testing? And I'm thinking specifically, there's a lot of labs moving to other rapid identifications, like MOLDI directly from the gram stain. That's the new hot topic at the moment. Do you think that there's a role for your system in that sort of environment?
Yeah, I think that's certainly something that we get asked quite a bit, and it's on the radar. It's not something that we're currently focused on. Our initial focus is working directly from specimens to eliminate the need to isolate, but there's nothing about the system that couldn't support that sort of approach. So it's definitely something we're considering.
Good. Okay. Full.
Hi there. Thank you very much. Very interesting talks. Philippe Legacy-Wins from Winnipeg in Canada as well. Very interested in your product. I was wondering how it would handle specimens that contain identical organisms, say 2 E. coli's, of which one is susceptible to, say, ceftriaxone, and the other one, say, has got a CTXM. It's not going to happen often with bloods, but it will with abscesses and such.
Sure. Great question. So the system does have limitations when there's morphologically similar similarities between organisms. There can be difficulties. It's very interesting when we look at the distribution or the heterogeneity of our plots. It's very clear when there's 2 distinct types of organisms present. For example, one resistant, one susceptible organism. When both are susceptible or both are resistant, it's almost inconsequential for that particular drug. But that is a very tricky situation that we have to be careful with from a reporting perspective. But there are some cases where it can be handled with very cleanly, and then others where we would simply say that we cannot report out a result for that particular combo.
Harald Seifert, Cologne, Germany. I have a question regarding the timeline. You said you had ID and AST within 5 hours. Is ID faster? So do you get this within 1 hour? And the next question is, what is about hands-on time per specimen?
Sure. Yeah, good question. And the clarification there is that it's an hour. About an hour to get an identification result from the system, and then 5 hours on average to report out a susceptibility result. And then in terms of your second question, I'm sorry, could you please repeat it again?
How about hands-on time?
Oh, hands-on time, yes.
Specimen.
So it's a matter of 30 to 60 seconds in terms of aliquoting a positive blood sample into the sample vial, loading the sample vial, the cassette, and the cartridge into the device and clicking a button. That's effectively what's required to run the system.
And is it random access? Because blood cultures turn positive continuously?
So the architecture is such that we have a module-based architecture where there are many modules hooked up to one system, one PC that controls as many modules as are installed at that particular institution.
I'm interested to see how the system will work for organisms that are phenotypically susceptible but may harbour resistant genes. Is there any difference to those that don't harbour resistant genes?
Yeah, another great question. So our current focus is correlating to MIC, and so the system actually takes all of the complexity that it sees and boils it into one number. There's certainly observations that we've made in terms of heterogeneity being greater or more significant in certain cases than in others. We have yet to correlate it to any specific phenomenon, but it's certainly something that we're considering whether resistance mechanisms may play a role in this sort of this phenomenon. We don't know, but it's certainly something that we're aware of and exploring.
Thank you. I'm from South Africa and I run reference laboratory for AST. So my question is that two questions. How you quality control your results? So can we use some ATC strains to control? Because otherwise and how repeatability of those results can actually be standardized, are they standardized, and how that actually line up with the other AST testing that they are currently available.
Okay. In terms of how we run quality control, we do use isolates that are very familiar to the community. So ATCC isolates are used and run on a QC dedicated run that happens periodically throughout the normal lab operating procedure. In terms of correlating the device result to an MIC, we've been very careful with controlling the broth microdilution method. We use a frozen broth microdilution method as our reference method for comparison. And we're very rigorous in terms of how we do those broth microdilution panels. And we've literally run over 20,000 broth microdilutions internally to support the development of the system.
And how is also compatible with other system costly-wise or cost effectiveness of the system?
Well, so I'll leave that to the marketing folks, but the cost, I think you can essentially consider it comparable to other similar sorts of technology, and I think that's about as close of an answer that I can give.
Hi, I'm Catherine Davis and I'm an ID physician from Australia. I'd like your opinion on what is our role in limiting this being at the bedside. I think it's because we don't think it's standard of care. And that's because we have interplaying factors between clinical chemistry for TDM, for pharmacy, for costs, and we don't come together to make some guidelines to make it standard of care. And because there's no available guidelines, there's no one saying this is what we should be having. And if we don't have that, then it's very hard to try and cost neutralise $200 per patient. But, you know, in Australia, we don't have a problem giving a $30,000 monoclonal to a patient for 12 months of extra, you know, quality of life over 60 years or whatever it may be. And I think we as a society need to get together and make some concerted effort to say that this should be standard of care.
Jim is already very excited about this question. He's like licking his lips.
Yeah, I'm sitting here chomping at the bit on this one. I have one word for you, amen. You know, that really does, and I thought your point of the monoclonal was absolutely brilliant. I think from a pharmacy and therapeutics standpoint, or pharmacy and therapeutics committee standpoint, I am perpetually amazed at the ability of the oncologist to bring in new drugs that will cost $1.5 million a year, and everybody does this. Yet we come in and want to talk about a new test that's going to cost $50, and everybody goes bonkers. You know, and so I think that is really one of the challenges, and I think the data that I presented from Robin's group at Rochester or at Mayo is I think going to really create, it's going to force some soul searching, and it's going to have to force some soul searching on how to do this. I think the piece, at least in the United States, that I think may drive some of this is the increasing emphasis that you're seeing from CDC on antibiotic stewardship. And I think that as that becomes more mandated and the importance becomes greater, I think you will see the attention of the C-suite and hopefully the purse strings loosen up a little bit. But as far as the need for kind of global consensus on this, could not agree with you more. I think the question is, how do we get to that point?
Just a quick translation.
I think the national
yeah.
thing, might be, we've had antimicrobial stewardship in Australia for many years and we still face the same issues. So that, I don't know, you
Yeah.
may be overly optimistic.
Yeah. Darn.
I'm wondering about, with this assay, the sensitivity in terms of how many organisms do you need in order to do a susceptibility testing? And does that impact on how long the blood culture has to be growing before you can actually do this type of test? That's the first thing. And the second thing is some organisms are very slow growing, and I'm wondering how you can approach that, or perhaps they may need media that is more supportive. So are those considerations as well?
Yeah, absolutely. Thank you. So in terms of to answer your question about how many cells are required, it depends upon how many tests that you'd like to run. So I think what I'll do is I'll answer the question in the context of running a single test, whether it be ID or AST. And the answer is not many cells. Now there's significant upfront processing that's required. That's what the sample prep is all about. But in terms of the number of cells that we analyze, it's in between 10 to 100 per microscopic field of view across 24 fields of view. So if you do the math, you can figure out how many organisms are in our device when we run a susceptibility test. Fish has a little bit more flexibility in terms of the number of organisms, both higher and lower. But yeah, and in terms of organism growth, yeah, we definitely see differences in organism growth rate, and we need to add the usual kinds of supplements for things that are typically fastidious, and there's basically no surprises there in terms of growth or nutrient requirements for our system.
So I want to thank the speakers for a very lively session. And I think it was it's a really exciting technology, exciting times to be a clinical microbiologist at this moment in time. So I thank you all for attending.